ahead, and there's nothing wrong with ordering tests, more tests than you really need to do, but in order for you to make your diagnosis and to institute correct therapy, we showed what specific tests would diagnose what specific anemias. For example, haptoglobin, low, that's hemolytic anemia. Whereas if it's a true iron deficiency anemia, ferritin is going to be low, and if it's a hypochromic microcytic anemia, use ferritin to distinguish, for example, between ACD, anemia of chronic disease, and IDA, iron deficiency anemia. You remember that? Now, we then went in and spoke about all these different workups that you can do, and then we broke out into the topic of electrolytes. These are the most common things that you're going to measure on all patients. Patient who has a hyponatremia, there are 5 basic possible causes. We saw what those were, listed them from most common to least common being drinking too much water, and the least common being Bartter syndrome. Then we went in and talked about hypernatremia, of which there are only 3 possible causes. Once you understand this, it's very easy to work this up. How do you work it up? We worked it up by showing that you got to get a urine analysis, and it's the urine analysis that's going to give you the answer. Then we spoke about renal failure and how to diagnose it. High BUN, high creatinine. We can distinguish between so-called pre-renal syndrome and true renal syndrome by looking at the ratio of BUN to creatinine. If both BUN and creatinine are elevated and the ratio is approximately 10 to 20 to 1, that's renal. If it's much greater than 10 to 20 to 1, it's pre-renal. If it's renal, we can go further, and simply by doing an osmolality measurement on a fluid-restricted patient, if the osmolality of urine is higher by a factor of 1.2 than serum, the tubules are doing their job. The kidney is concentrating the urine, conserving fluids. That's its basic purpose. So the tubules are functioning, therefore the deficit must be at the level of the glomerulus. And of course, if the tubules aren't functioning, there has to be a tubular lesion. So by doing basically non-invasive tests that are very cheap, you can make the diagnosis and pinpoint the lesion. It's a very simple process. Now I'm going to take this a little bit further and talk to you about another very high yield, virtually, well, it is an invasive test in a certain sense, but it's minimally invasive, and that's the so-called arterial blood gas. And I want to talk to you about that today, and I want to go a little bit into liver function tests. Before I do this, however, I'd like to show you, just to give you a feel for what some of the different types of the anemias that we spent so much time on last week really look like when you look under the microscope. And so, Sandy, if you can show me the first slide, I'd like to just show you a typical iron deficiency anemia pattern, followed by a hemolytic anemia pattern, followed by a macrocytic pattern. Now, let's see. We can turn out some of the lights here. Let's see. Let's go out on. Well, I don't need that. Where are they? They're here? These ones?
Yeah, top to top.
These.
Yeah,
All right. There we go. Okay. Thank you very much. Appreciate that. Now, I think you can see very clearly what's going on here. Take a look at what these cells look like. They're very, very, by the way, anytime you want to compare, this is a typical poly. You compare, it's much larger than the average erythrocyte. Notice what the erythrocytes look like, though. They're very pale. This is what an erythrocyte should look like. This is what it actually is looking like in a large population of these cells. A very large central area of pallor that's white on the interior. You can see this virtually over the entire slide. If this thing works, I don't know if it does or not, probably not. Oh, it does, Mike. That's, it's amazing. This, you see these particular, look at this one in particular. You get the impression that these cells have a very large white area that they shouldn't have. They should be looking like, as we said before, something like this cell or even that cell. And this is typical of the iron deficiency anemia pattern. Now let me show you what a hemolytic anemia looks like. Sandy, you want to just show the next slide? Take a look at that. Well, this actually, it looks like a sickle cell anemia. It's typical sickling. This is probably a nucleated red blood cell, but not a very good representation of one. But notice that you have these schistocytes, the fragmented forms. Actually, sickling is a form of a schistocyte. The cells sickle because of abnormal hemoglobin, but then the spleen takes a large bite out of them, and they have this characteristic appearance. Here's one, here's one, here's one. This cell is being, there's a destruction of cells peripherally. Notice also the extreme poikilocytosis, the difference in shape of the cells from as you go from cell to cell. There are some what we call target cells here also, where the cells show central targeting. That's due to condensation of RNA, mostly RNA products, and that's typical in the hemolytic anemias to see that. It's also typical of liver failure. Here's a perfect example of the so-called Burr cell. Take a look at these. Now, it turns out this is from fixation artifact that can sometimes happen to you if you do the smear incorrectly. But it is a beautiful illustration of what you would see in a patient who, say, is splenectomized, who has a severe hemolytic anemia. You see these cells that have that sort of starfish appearance. Some people call these echinocytes, Burr cells, any of those. This is probably a monocyte over here, or a macrophage, which is highly vacuolated. At any rate, you can take a look. This is the typical pattern that we talked about, the Burr cell, echinocyte. You saw what schistocytes look like. If you just show the next slide, Sandy. Could you focus it a little bit? No, it's not focused very well. I'll have to talk to Bob Hutchison about that. Oh, well. At any rate, see this? This is a fragmented form here. You'll notice the extreme poikilocytosis. Here's another fragmented form, many fragmented forms on the slide. These are all fragmented forms that are actually superimposed on relatively normal red blood cells. But at any rate, I think you can see that there's a significant poikilocytosis, difference in shape, fragmented forms, and a so-called anocytosis, that is, very different cell sizes. Compare, for example, this cell size to the cell right next to it. It's the difference between day and night. And there's a lot of that on this slide, as I think you can see. Now I'll show you a macrocytic anemia. If I just have the next slide. And this is a little bit difficult to see, but again, always compare the red cell to, well, this is a nucleated red blood cell here. It's always good to look for a poly on the slide. We don't happen to have one here, but look at this nucleated red blood cell. It's significantly larger than the typical erythrocyte because it's a precursor form. And the farther up the ladder you get in the precursor forms, the larger the cell tends to be. Here's an typical erythrocyte. This is what it should look like. But take a look at these cells. Look at this, and that. They're approximately the same size as this nucleated red blood cell. Look at this one down here. It's bigger. And this is what we call a macrocytic pattern on the peripheral blood smear. If you looked at the bone marrow of this patient who has a true macrocytosis, remember the MCV, the mean corpuscular volume, is going to be higher than the usual upper limit of normal, which I think in our lab is around 97 femtoliters. This one I would estimate would probably be somewhere on the order of 105, significantly larger than the highest normal volume that we would measure. And this is what it would look like, actually, if you looked at the smear. I just wanted to give you a sense for what these things actually look like, when you look with your own eyes, as you sometimes will on the wards when these types of anemias occur. You don't have to, because you have the numbers. You may want to, especially in the hemolytic anemias, as we discussed last week. Now, I'd like to go back and talk about the concept of arterial blood gases. Now, we spoke about the, thanks very much, Sandy, that was great. We spoke about the diagnostic value of doing specific tests, how we use the sodium, and then we can use the urine analysis. There's one set of tests that you can order which at one glance will tell you the entire metabolic status of an individual. That metabolic status is reflected in the oxygen content of the blood because, after all, the whole purpose of the blood is to get oxygen to the tissues. So it'll tell you not only how much oxygen you're getting into the blood, but how much carbon dioxide is coming out of the tissues that are metabolizing, and will tell you at one glance from one number, namely the pH, what the overall metabolic status of the individual is. Is the patient acidotic or alkalotic? And it will give you, again, as I say at a single glance, the entire picture for what this patient really is doing when you're making the measurement. Now, generally speaking, we don't order arterial blood gases on every patient who comes in. So far, all of the tests that we've ordered are tests that tend to be routinely ordered on patients. These tests the arterial blood gases are ordered on patients who are very sick and tend to come into the emergency room or the ICU. Nonetheless, the values are very informative, and let me show you why. Specifically, what we measure with arterial blood gases is 4 values, only three of which are independent of one another. Now let me show you what those are. I'll list these off for you first so you can see exactly what it is we're measuring. By the way, an arterial blood gas in our laboratory takes approximately 30 seconds to do. You bring it down on ice. Now, I said it is an invasive procedure. It is more invasive than just drawing blood because you're taking the blood from an artery. It's usually the radial artery. You feel for the pulse, and you take of course, a sterile needle, which is a very short needle, and you stick it in and watch for pulsatile flow in the syringe. That's how you know you got into the artery. Sometimes you miss the artery, you get into a vein, and then the measurement becomes invalid. You want to see how well the lungs are oxygenating the blood. You can't tell that by looking at the venous return blood. You can only tell it by looking at the arterial component of that, and that's why we want to get the arterial blood rather than the venous blood. Now, there are some elegant techniques that we can use that are coming out slowly on the market, which is, for example, to look at the capillary circulation in the earlobe. That's all oxygenated blood. And by simply getting earlobe blood, which, by the way, can be done totally non-invasively, we can get exactly the same measurements we do by getting the arterial blood gases from true arterial so-called sticks. That is, you put the needle into the radial artery and get the blood out that way. At any rate, most of the time we do it that way. I think in the next perhaps 5 years, that whole measurement is going to go out. That measurement won't go out. The technique will go out. Will be replaced by a non-invasive earlobe method. It's very nice how these things keep developing. And it's going to, of course, then it'll be a totally non-invasive technique, and this can be done routinely on anybody without worrying about rupturing an artery or having a severe arterial bleed and that kind of thing. I want to mention to you that when you do these techniques on the wards, which you will start doing, if not this year, certainly next year, when you're finished, make sure that you keep an alcohol pad or a pressure pad on the area where you inserted the needle. It's very important because this is arterial blood. It's under tremendous pressure, and you want to make sure you have a counter pressure. Stand there for at least 2 or 3 minutes holding it. Make sure that there's no bleeding when you're about to walk away to get the blood to the laboratory. Very important to keep these bloods on ice because if you don't, CO2 from metabolism of red cells begins to come in and messes up the measurement of the partial pressure of carbon dioxide. Now, let me show you what the measurements are that we make. They are as follows. This is set up. Here we go. Can you all see this? Again, it's large enough. You want me to put it up higher? Let's see. Do that. How's that? Okay. Is this good for everybody? The measurements we make, I'm just going to turn this around for a second, are pH, PO2, PCO2, and bicarbonate. Now, these values, as I say, the PCO2, the pH, and the bicarbonate are all related to one another. If I know the pH and the PCO2, I can back calculate the bicarbonate. If I know any 2 of those values, I can always calculate the third from the so-called, if you may remember, the Henderson-Hasselbalch equation. Now, I'm going to go over this because it's extremely important in making a diagnosis of a patient. Many of your patients are going to have diabetic ketoacidosis. How are you going to make that diagnosis? How are you going to diagnose that the patient has a metabolic acidosis? The 2 most common causes of metabolic acidosis are, in fact, diabetic ketoacidosis and sepsis, especially gram-negative sepsis. We mentioned a little bit about that last week when we talked about the cholestatic pattern, the mild elevation of the bilirubin and the alkaline phosphatase. Well, I'm going to go over that now and show you how you make this diagnosis. In fact, let me write the Henderson-Hasselbalch equation for you. I know it's a dirty word among most medical students, but the fact of the matter is it's really quite useful in this diagnostic context. And that is that the pH of blood, this is arterial blood now, is equal to pKa plus the logarithm. And now, unfortunately, I'm running out of space here, so let me rewrite this. I'll rewrite it write it this way, that the pH, I'm going to write it down here for a good reason, equals to pKa plus the logarithm of the bicarbonate over the H2CO3. Now, what we're really looking at here is we're looking at carbonic acid dissociating to bicarbonate plus a hydrogen ion. And the way this looks is the following. First of all, we take carbon dioxide, react it with water to form H2CO3, and then the H2CO3 dissociates to H plus HCO3 minus. Now I'm going to put this up here so you can see it. I've run off a little bit, but I'll keep moving it back and forth. That's about the best I can do. Now, what I want to show you here is the following. This pKa is the negative of the logarithm of the dissociation constant for H2CO3 going to hydrogen ion plus bicarbonate. That's all I want you to know. That number at room temperature and atmospheric pressure is equal to 6.1. 6.1. Let me put that down. It's not very clear. I'll make it a little bit bigger. 6.1. Now, I want to call your attention now to the denominator of this equation. The denominator of this equation is carbonic acid. The only way we can get carbonic acid is by mixing carbon dioxide and water, as we have over here. Carbon dioxide and water goes to H2CO3. I can write an equilibrium constant for any equilibrium. And the equilibrium constant for this reaction, this first piece over here, is very simple. It's H2CO3. Let me just write it down here for you. It's this equilibrium constant K is equal to H2CO3 divided by H2O times CO2. K is equal to H2CO3 divided by CO2 times H2O. Equilibrium constant, like you would, the way you'd write for any equilibrium. Very straightforward kind of thing to do. You can always write a constant. Now, for an equilibrium anyway. Now, this carbon dioxide that I'm talking about is the actual amount of gaseous carbon dioxide dissolved in water. Serum is mostly water, and that's what that is here. Water dissolved in water is constant. That's always a constant number, so that you don't even have to worry about. In other words, this constant really depends upon only the ratio of carbonic acid that's created by this reaction to the concentration of CO2 dissolved in serum, water. Okay, now that that's true, I can make another statement. It's a very simple statement. Suppose you have a container that's sealed. It's half filled with water, and I put different amounts of gas, say carbon dioxide, mixed with oxygen, into that container. Now, the higher the pressure of carbon dioxide I have inside that closed container, the more carbon dioxide is going to get dissolved in the water because I'm virtually forcing it to go into the water. The lower the pressure, the more is going to tend to come out of the water and go up into the gaseous phase, which is above that water. Now, the amount of carbon dioxide dissolved in the water is proportional, therefore, to the pressure of carbon dioxide in the gas phase above it. That's all I'm saying. That's an intuitively, we would all expect it to be that way. It turns out to be, in fact, very accurately that way. And so that's true. Since that's true, I'm just going to simply say that CO2 is proportional, well, I'll actually write this out as equals to K, some little constant, times the pressure of carbon dioxide in the gas phase, in the gas phase above the solution. Now, in that case, I can then say, instead of writing CO2 for the CO2 dissolved in water, I can say that this CO2 is really equal to K times PCO2. Now notice that the carbonic acid concentration is equal to this constant, that constant for the equilibrium, times CO2 itself. But since CO2 is equal to another constant times PCO2, then overall I can say that carbonic acid, I'll write this out down here if I have any room, carbonic acid H2CO3 is equal to some other constant, let me just call it C, times PCO2. That's very important because that allows me to write the Henderson-Hasselbalch equation as bicarbonate divided by some constant times PCO2. And that's right over here. Now, that's great. Because where can you get rid of CO2? The lungs. Where can you excrete or retain bicarbonate? Kidneys. The Henderson-Hasselbalch equation is really telling you that the pH of blood is equal to 6.1 plus the logarithm of the kidneys divided by the lungs. That's really what the Henderson-Hasselbalch equation says physiologically. That's an extremely important point. Why? Suppose a patient comes in with a metabolic acidosis. What does that mean? It means that the patient is producing too much acid. Let's say it's acetoacetic acid from fatty acid metabolism, because the patient can't metabolize glucose if the patient is a diabetic. This is also, by the way, a pattern seen in starvation. It's seen in a variety of different conditions. Diabetes, alcoholism is another one, a terminal alcoholism, that gives that type of pattern. Good. Okay, if that's true, then what are you doing? It's as if you squirted acid into the patient. Now, there's only one thing that can take up the acid in this patient. That's bicarbonate. It's a base. And when it gets converted, it reacts with that acid to form carbonic acid. Now, the body's uniquely poised to get rid of it. Why? Because over here, and I didn't have enough room on here, but I can get rid of that carbonic acid as CO2 and water. Every time you breathe off CO2, 1 mole of CO2 is 1 mole of hydrogen ion, of acid. You're breathing acid off all the time. That's how your lungs are actually regulating the pH of blood. Now, let's put some numbers into this Henderson-Hasselbalch equation for me to show you illustratively what actually happens in the regulation of the blood pH. This number is 6.1. Bicarbonate levels in most human beings are around 24, 25 milliequivalents per liter. Carbonic acid, as we saw, we can express as PCO2. PCO2 in most humans, normally breathing and under normal conditions, is about 40 millimeters of mercury pressure. In the gas phase above, the so-called solution phase, that's the pressure in the lungs, essentially, which is exactly the same thing as what it is in the circulation. Now, given that, since that's true, then this ratio of bicarbonate, then this is 24 divided by some constant times 40. Now, if you measure that constant, and it is truly a constant, that comes out to be the number 0.03. 0.03 times 40 is 1.2. So this number comes out to be 24 divided by 1.2, which is the number 20. Now, remember, I'm taking a logarithm over here. The logarithm of 20, you can take my word for it, is 1.3. 1.3010 to be exact. 1.3 is between you and me and you. 6.1 and 1.3 gives you 7.4. That's the origin of the pH of blood, 7.4. That's the lungs are maintaining it that way. Mind you, the bicarbonate carbonic acid equilibrium is a lousy buffer for blood. If you wanted to maintain your blood at pH 7.4, I would never choose the bicarbonate carbonic acid buffer. I would go to a phosphate buffer. The body doesn't do that, though, because it knows it's got the lungs, and the lungs can get rid of CO2. The more CO2 it gets rid of, the smaller this denominator becomes. The larger this fraction becomes, the higher the pH becomes. So the body is regulating your pH through the Henderson-Hasselbalch equation using the carbonic acid bicarbonate equation, because you see the body can volatilize the acid in the form of carbonic acid, which is just CO2. So it can get rid of that CO2 immediately. Is this clear? Does it make sense? Now, having said this, let's go through 4 discrete situations that you will see commonly on the wards. And I want you to be able to instantaneously make the diagnosis of what this patient has. There is one and only one principle I want you to remember here, and that is this. A patient does not have acidosis unless his blood pH says that he has acidosis. The patient should have a blood pH of 7.4. If it's 7.3, the patient has acidosis. If the patient has a blood pH of 7.4 and a bicarbonate of 10, the patient does not have acidosis. I'm sorry. That is unacceptable. There is no such a thing as acidosis without you having acid. And if the patient doesn't have an excess of acid, he does not have acidosis. Likewise, alkalosis. If the bicarbonate is 100, I don't care how high it is, it never will be. If the bicarbonate, instead of being 24, is 35, and the patient has a blood pH of 7.39 or 7.4, the patient does not have an alkalosis despite the fact that the bicarbonate is high. This is an extremely important point that you must remember. Don't make the diagnosis of acidosis by looking at the bicarbonate level. That's wrong. The same thing is true of the PCO2. The PCO2 may be high, then the denominator may be low, and the patient may have a so-called respiratory acidosis. No, the only way you make the diagnosis is by looking at the first and most important measurement in blood gases, and that is the pH. You must look at the pH first. Then you can focus on what the possible cause of that particular abnormal pH is. Now let's talk about the 4 different circumstances that actually occur in patients who come in with abnormal blood gases, who have abnormal pHs. And let's divide this up as follows. Let's talk about the condition. I'll try to make this as condensed as possible. The blood pH, the bicarbonate, and the PCO2. That's all I'll put down here, just so we can fit it on here like that. That's good. There are 4 conditions, and only 4 conditions. There are 2 types of acidosis and 2 types of alkalosis. The 2 types of acidosis are metabolic and respiratory. The 2 types of alkalosis are the same 2, metabolic and respiratory. Let's look at those. So let's talk about metabolic acidosis, and then let's take the metabolic alkalosis, then respiratory acidosis, and finally respiratory alkalosis. Now, anytime I have an acidosis, the pH has to fall. Big drop in pH, metabolic acidosis. Typically, these patients have blood pHs of 7.2, 7.18. You'll even see a 6.9. See a pH of 6.9, you got to get that patient corrected instantaneously, otherwise the patient's going to die. We've seen it. We just saw one very recently. What was it, 6.8, I think it was. Yeah, it was terribly low. It was, got to correct it immediately. Now, I'll show you how in just a second. That's got to be a metabolic. Usually respiratory acidosis, unless the patient has severe chronic obstructive pulmonic disease like terminal emphysema, the pH will not drop usually much below 7.3. It'll be low, but not so low as something like 6.9, 7, 7.1, even 7.2. The primary problem in a metabolic acidosis is the consumption of bicarbonate. That's the primary problem. Therefore, the very first thing you will see is a loss of bicarbonate due to the fact that that buffering system is buffering. Bicarbonate has been consumed by the acid you've shoved into this patient, whether it comes from acid you've added exogenously or it comes from fatty acid metabolism in a diabetic, the person who's in starvation or who's an alcoholic, or it's from lactic acidosis secondary to sepsis, blood not reaching the tissues now going over to anaerobic metabolism. So the big change here is that the bicarbonate falls very, very dramatically to values like 12. If you have a patient whose pH drops and who has a low bicarbonate, then you make the diagnosis of metabolic acidosis. Only then when you have that measurement of blood pH, which is low. Now, by the Henderson-Hasselbalch equation, as I showed you just a moment ago, the denominator has K or C PCO2 in it. Now, if suddenly the bicarbonate, the numerator falls, the lungs pick that up and they say, all right, let's just get rid of more CO2. So if the numerator decreases, the denominator decreases in proportion. You blow off more CO2. Many of you will have already encountered a patient in diabetic ketoacidosis who undergoes what we call Kussmaul breathing. Kussmaul breathing is where they're breathing like this. Why? It's not out of their own volition. It's because their lungs are telling them that they've got to get rid of more CO2 because they're producing enormous amounts of acid from acetic acid. These patients can go into coma very, very rapidly if that acidotic condition is not corrected. Now, so what happens to the PCO2? Well, the PCO2 falls. It actually falls. It'll go down. Most commonly, the compensatory process is not perfect. So the patient will remain in acidosis. It's nature's way of telling you, I'm not going to compensate exactly because then you won't pick up the disorder. So I'm not going to compensate. I will compensate to save the patient, but I'm not going to compensate so much that you won't be able to make the diagnosis. That's what essentially is happening. So the patient will have a low pH, a low bicarbonate. The patient will partially compensate. The PCO2 will go down, but not completely, so that the patient still will be in acidosis, slight acidosis. So a patient who has a low blood pH, a low bicarbonate, and a compensating low PCO2, you've got the diagnosis clinched as a metabolic acidosis. Now, metabolic alkalosis is very simple. All I got to do is reverse all these arrows I've just drawn for you. The body is retaining too much first of all, of course, the pH is going to go up significantly above 7.4. The body is going to be retaining too much bicarbonate, and because of that, you're going to breathe more slowly. Not to get rid of CO2 so fast, because the numerator is increasing now, bicarbonate's being retained, so I want to retain CO2 in proportion to that. Therefore, the PCO2 goes up. In a patient who has a blood pH higher than 7.4 with a higher than normal bicarbonate and a compensatory increase in PCO2, the diagnosis is clinched. No problem there. Now let's go over to a very interesting condition, which is respiratory acidosis. Since it's an acidosis, the very first thing we see is that the pH drops, like that. Now, what's the primary problem? It's not with the bicarbonate. Something's going on with breathing. You're retaining too much CO2. CO2 retained is going to make that denominator large, which is going to drop the overall pH. Well, if that's true, then the primary problem is CO2 retention for whatever reason. Let's not worry about the specific reasons yet. So here's the primary problem. There's going to be a rise in the PCO2. Now, what's the body going to do? Well, the body sees that the denominator is increasing. We don't want the denominator to increase and that fraction to go down. The log of bicarbonate over C PCO2. CO2 is going up. I want to increase my numerator. So I'm going to retain bicarbonate. Where? In the kidneys. So the bicarbonate's going to go up to compensate for that increase in the PCO2. Now, notice what happens here. Suppose this patient came in and you picked up a high bicarbonate. The bicarbonate, instead of being 24, is 30. Oh, well, this patient has an alkalosis. No, the patient doesn't have an alkalosis. The patient has an acidosis. He has a respiratory acidosis that's being compensated by retention of bicarbonate. That's what he does. That's not, the bicarbonate isn't abnormal. It's the acidosis that's abnormal. So never make the diagnosis of alkalosis or acidosis on the basis of the bicarbonate. This is the point that I'm trying to illustrate here. Now, by the way, you'll notice that there's a fall in the arterial blood gas pH in the face of a rise in the bicarbonate. The bicarbonate's higher than normal, not lower than normal. Well, there's only one thing that can cause that. That's a respiratory acidosis. If it were a metabolic acidosis, the bicarbonate should have fallen the way it did over here. Okay, the last condition, of course, is respiratory alkalosis. Since it's an alkalosis, the arrow is going to point up. It's going to be a higher than normal pH, blood pH. What's happening here? You're breathing off too much CO2. The denominator is getting small, making the fraction larger. So, to compensate, you want to get more, because the denominator is going down, you want the numerator to go down also. So the kidneys now will excrete more bicarbonate, and as a result of that, we get this. Now notice, this is a respiratory alkalosis. Respiratory alkalosis. Notice the pH is going up. Had I only looked at the bicarbonate, I would see a decrease in the bicarbonate, and I would say this patient has a metabolic acidosis. Not true. The patient does not have a metabolic acidosis. He has a respiratory alkalosis, just the opposite of what you said. So it's very important, again, to measure the pH. Look at the pH and then make the diagnosis. Do not look at a venous bicarbonate. It will not tell you anything at all about the metabolic status of the individual. Now, having said that, what are the possible causes of these things? We've already spoken about metabolic acidosis. That's easy. We've spoken about diabetic ketoacidosis and lactic acidosis, and sepsis as being by far and away the two most common causes. Occasionally, poisoning will be one where the patient attempts to commit suicide, ethylene glycol poisoning, methanol poisoning, ethylene glycol going to glyoxylic acid, and methanol going to formic acid, giving this acidotic state. Now, metabolic alkalosis, what's the most common cause of that? Well, if you think about it, you all know this, the most common cause is vomiting. Why? Because you're vomiting off HCl. That's what's being produced by the stomach. HCl, as you get rid of hydrochloric acid, you're getting rid of acid, increasing the base content of the body, and that's bicarbonate. So the bicarbonate primarily goes up. If you see a metabolic alkalosis, think vomiting. You got to get a good history here. Now, in terms of respiratory acidosis, as we already mentioned, the most common cause, of course, is COPD, chronic obstructive pulmonic disease. Pneumonia tends to cause restrictive disease and usually does not give a respiratory acidosis unless it's very severe and has an interstitial component to it where alveoli may actually be weakened, and so there is some CO2 retention. But generally speaking, garden variety, so-called pneumonia, like pneumococcal pneumonia, Klebsiella pneumonia, that kind of thing, things that cause lobar pneumonia, that will not cause, or even bronchial pneumonia, will not give you a respiratory acidosis. COPD does. We're going to talk a little bit more about this in just a moment because it will affect your treatment of patients, and I want to go over that. It's extremely important. But at any rate, respiratory acidosis, COPD, very important. You now know how to make the diagnosis. First, drop in the pH, first and foremost, with a rise in the bicarbonate and, of course, the PCO2. Respiratory alkalosis has really only one cause, by far and away the most common, is panic. Before exam time in medical school, not an insignificant number of medical students will go to the emergency room with paresthesias, tingling in their fingers, even right-sided or left-sided weakness, et cetera, et cetera. The reason that this happens is because you breathe off, when people hyperventilate, they breathe off too much CO2. And of course, that lowers the denominator in the Henderson-Hasselbalch equation, raising the blood pH temporarily. The body then gets rid of compensatorily the bicarbonate via the kidneys. So we have a respiratory alkalosis. Now, if you drop the PCO2 of blood too fast, the blood is, of course, in equilibrium with CSF. The PCO2 of CSF falls, and if that PCO2 is outside of a certain range in the cerebrospinal fluid, what happens is that nerves become hypersensitized, or actually, I should say, desensitized, because they stop firing, really, in response to stimuli, so that a patient will actually can have sensory loss, sensory deficits, and even motor deficits. It's paradoxical in a sense because, as I'm going to show you in a few minutes, if you retain too much CO2 so that there's a sudden rise in the PCO2 of cerebrospinal fluid, you get what's called CO2 narcosis, which also gives rise to things like paresthesias and motor loss. It's very interesting how that happens. No one quite understands the mechanism for the drop in CO2, although we understand the rise in the PCO2 much better. At any rate, the most common cause of this is hyperventilation due to a sudden drop in the serum, the whole blood PCO2 that we get from arterial blood gas determinations. The treatment for this is very straightforward. The treatment for this is simply to let the patient breathe back the CO2 that he's already breathed out. It's very simple. Have him breathe into a bag, let the CO2 get up in the bag, and then let him rebreathe his CO2. That will increase the CO2, and like magic, In the patient who comes in with a hyperventilation attack, the patient will lose the paresthesia just as fast as they came on. So it's a very simple, straightforward thing to do, and you can use any kind of bag, a brown bag, a plastic bag, any of these things. You don't want the patient to suffocate, but you have them rebreathe that CO2 and it'll go away. This is the basic. If you can understand this, you will be able to diagnose all of your patients on whom you've ordered an arterial blood gas by looking at the values in this order: pH, bicarbonate, PCO2. Now, there was one other measurement I mentioned, which is PO2. What is the significance? Why do I even bring that in here? Well, PO2 is reflecting, in essence, the amount of oxygen that's getting to the tissues. If this is the O2 in arterial blood, that's the amount that has to be delivered to the tissues. Now, there's one obvious exception to that, and that's where you form an anastomosis, as you do in sepsis. That is, the arterial blood anastomoses with venous blood, so it never gets to the tissues, but the oxygenation is perfectly fine. Very unusual to see that in a large way, although it does happen. But that is an exception to the rule. However, of course, one will see a buildup, a tremendous metabolic acidosis, secondary, as we said before, to a lactic acidosis in that patient with, say, gram-negative sepsis. Now, where does O2 come into the equation with PCO2, pH, and bicarbonate, the Henderson-Hasselbalch equation? Well, the answer is it is purely mechanical. In your lungs, you have an alveolar sac. Let's draw a nice large alveolar sac here. Let's draw it like this. And here's the terminal bronchiole, the respiratory bronchioles coming in here like this. Now, when you breathe in air, you're breathing in mostly O2 and, of course, nitrogen. You're breathing off CO2. So there's this constant competition for the same airspace between oxygen molecules and CO2 molecules. Oxygen's coming in, and CO2 is going out. Now, let's take a look at what happens. Well, for most normal people, they're good friends, they get along, there's no crowding. You can breathe in more oxygen or a little less oxygen, and the CO2 won't crowd it out. You can give off a little bit more CO2, especially if you're running, etc., and there's more CO2 in the lungs. And you still get the same amount of oxygen because the space is big. But there reaches a point where, say, a patient has COPD, where the patient can't breathe off the CO2. It doesn't leave that space. It keeps accumulating. Well, eventually, there reaches a point where all of a sudden the oxygen wants to get in but can't. The space is blocked. Too much CO2. Now, let's take a look. It's a very simple relationship between PO2 and PCO2. Let me draw it for you like this. Here's PO2. Let's do it this way, PO2. And here's PCO2. Most of the time, PCO2 should be around 40 millimeters of mercury, approximately. And the PO2 is perfectly content. Now we're going to raise the PCO2 on this patient. All of a sudden, we observe something that looks like this. Why? Very simple. Crowding. Where does it start to happen? At PCO2s of around 50 to 55 millimeters of mercury. Right over here. 50 to 55, oops, did it again, 55 millimeters of mercury. Now, all of a sudden, you get on this downslope over here. The more CO2 that accumulates, the less O2 gets in. Now there is competition. Now the PCO2 value begins to affect the oxygenation of tissues. Now this has a terrible consequence for the patient because of something else that happens, which is referred to as the respiratory quotient that works against you because of the inefficiency of the body. Remember, for the oxygen that you take in, ultimately you want to Krebs cyclize it. So you want to oxidize glucose to CO2 and water. So per 1 mole of oxygen, you want to give up 1 mole of CO2, mole per mole. Ultimately, you want to burn whatever you can efficiently. The body isn't efficient. For every mole of oxygen consumed, only about 80% of the total CO2 that should be produced actually is produced. So the CO2 given off to the oxygen consumed gives us a ratio of approximately 0.8. That is 4/5, something on that order, something 80%. So we have what's called the RQ, the respiratory quotient. The respiratory quotient is equal to, let's see, CO2 produced to O2 consumed. And this ratio is about, as I say, about 0.8. Now, 1 over 0.8 is about 1.2. Now, this tells me the following. This tells me that oxygen, let me write it this way. CO2 is equal to 1.2 times O2. I'll put it in those terms. Okay? That is, the CO2 produced is equal to, the oxygen, no, I got that wrong, I'm sorry, excuse me. Should be just the reverse. The O2 that's consumed is equal to 1.2 times the CO2. I'm sorry, I just exactly reversed that. I'm getting blinded by this thing already. Anyway, that's an important relationship. The reason it's an important relationship is the following. If the PCO2 should go up by 1 unit, the oxygen in this region of the curve is going to go down by 1.2 times as much due to this respiratory quotient equation. Again, O2 is equal to 1, I ran off the thing here, is equal to 1.2 times the CO2. I'm going to rewrite that over here so you can see it more clearly. O2 is 1.2 times the CO2 from the respiratory quotient equation. Very simple equation. Due to the inefficiency of the body for completely efficiently utilizing the oxygen it takes in. Now, if the CO2 should happen to rise in this region here, the oxygen is going to go down by 1.2 times as much as the CO2 has gone up. So in other words, you are doing far worse by 20% in getting oxygen into your lungs. Every time the CO2 goes up by 1 mole, the oxygen goes down by 1.2 moles in that alveolar sac. Now you have a real problem because there's a disproportionate decrease in the PO2 given an increase in the CO2. Now, let me go in and talk to you a little bit about this and tell you what, well, first of all, I think you can see that one consequence of this is that there is going to be a severe acidosis that will result, a metabolic acidosis that will result. Why? Because every single time you get a disproportionate decrease in oxygen perfusion in blood due to this increase in CO2 in the alveolar sac, the tissues are not going to be able to metabolize aerobically by a disproportionate amount, that 20%. That's 20% that you're going to have to make back up, creating lactic acid. There's your lactic acidosis. That gets into another problem, and that's this. We all know how oxygen has to get delivered to tissues. The oxygen gets delivered to tissues by binding to hemoglobin. Now, one thing you should remember is that oxygen, unlike CO2, is not soluble in anything. When it gets into the lungs, it's got to diffuse across the alveolar wall. It's got to get through a basement membrane. It's got to get into the interstitial space. Then it has to get across the endothelium. Then it has to dissolve, which it can't, in water, which is the vascular space. Finally, it's got to get across the red cell membrane. And of course, at last, it can bind to the only thing that it is soluble in, and that's hemoglobin. Now, we all remember, I'm sure if you don't remember, don't worry about it. You'll remember it right now. We'll go over it, which is the so-called oxygen-hemoglobin dissociation curve. And that looks like this. I'm running out of ink, so I'll get I come armed to these things. Here we go. I'll put it in green. I have a mixture of colors here. I don't know how well this shows up. This is going to be what I call saturation. And that means if I look at a typical set of red blood cells, how much oxygen can I add to them before I completely saturate all the hemoglobin? Now, I can measure this very easily in a matter of 2 or 3 seconds spectrophotometrically, because oxyhemoglobin has a unique band that deoxyhemoglobin does not have. And if I focus a spectrophotometer on that band, I can observe an increase or a decrease in that band and tell you exactly how much oxyhemoglobin I have. If I keep adding oxygen to the blood and I see the band get higher and higher until finally it no longer saturates, I can say how much saturable hemoglobin I have. So I can measure the percent saturation of hemoglobin. So I'll call this percent sat. And here is going to be PO2. PO2 is exactly the same conceptually as PCO2. That is, it's the partial pressure of oxygen in equilibrium with the dissolved oxygen in liquid, the liquid being blood here. Now, you may remember that the oxygen-hemoglobin dissociation curve is S-shaped. It looks like this, and I'm going to draw this for you so it's a nice S. Now, I want you to see it clearly. Notice this. Saturates. Usually, it saturates at an oxygen pressure of about 100 millimeters of mercury, 90 to 100 millimeters of mercury. Now, suppose I sort of slip. Now, the reason this curve is S-shaped is because of the phenomenon of what we call the allosteric nature of hemoglobin. Hemoglobin consists of 4 chains. Each of those 4 chains contains a heme. Each of those hemes can bind an oxygen. It's very hard for oxygen to get onto the first heme of an unsaturated hemoglobin molecule, but once it does, the molecule changes its conformation and it makes it a little easier for the second molecule to get in. That makes it much easier for the third to get in, and finally for the fourth, it's a piece of cake. No problem at all. That's what this says over here. Very hard for the first one to get on, easier for the second, very easy for the third, and the fourth is a piece of cake. You're saturated. That's what this curve is saying. Now, I'm going to just go about doing the reverse. I'm up here where it's a piece of cake. So it's very easy. It's very hard to get rid of this oxygen. It stays, and all of a sudden I come to a certain partial pressure of oxygen where all of a sudden I go shooting down. In other words, for a very, very small change in the partial pressure of the oxygen, my saturation falls instantaneously from about 70%, which it would be over here, down to about 30%, which it is down around in here, in this region of the curve. That's bad. Now think about what I just said to you just a second ago. The respiratory quotient. The patient has COPD. He's building up CO2 in his lungs. He's not exchanging his gases. For every mole of CO2 he's retaining, he's losing 1.2 moles of oxygen. What's that doing to the PO2? It's reducing it by 20% greater than the PCO2 has been increased. That pushes me down this curve very fast. Now I'm over here. I'm right at the edge, the ledge of this precipice. Any further decrease in my PO2, all of a sudden, this despite the fact that I may be getting oxygen into this patient, even with a mask or on a respirator, the saturation is falling, and it falls to 30%. So now I can't saturate. I'm not getting oxygen, despite the fact that I'm pushing it into his lungs, it's not binding to the hemoglobin, because the CO2 crowding effect has taken effect. And so I've now lost that ability for him to get oxygen to his tissues, despite the fact that I may try to be pushing oxygen through. Now, that has very severe consequences, because what's going to happen? Well, we already said it. The tissues are going to now go over to anaerobic metabolism. That's lactic acid. What does that mean? It means there's an acidosis. But what happens when you have acidosis? When you have acidosis, you shift the oxygen-hemoglobin dissociation curve, you may remember, to the right. That means this. Now we got a real problem, because we may have fallen down here temporarily, but look at what goes on. If all of a sudden you've shifted, here's your PO2, you've shifted your oxygen hemoglobin dissociation curve, this PO2 now means that much saturation rather than this much saturation. It's the difference between here and here, because I now have shifted the curve due to the lactic acidosis. Well, that means that the tissues are getting even less oxygen. And the less oxygen they get, the more lactic acid they produce. The more lactic acid they produce, the more the curve shifts over, until finally no oxygen gets to the tissues and the patient dies. Very serious condition. This is the typical pattern we see in two instances. The first is a myocardial infarction, where the heart just can't put out the blood necessary to get oxygen to the tissues. The second is in a pulmonary embolus. The PO2 falls simply because the blood simply, again, it can't get oxygenated in the lungs because a major pulmonary embolus is saddled, and so you can't get oxygen, blood into the lungs to have CO2 oxygen exchange. Of course, in severe COPD, this is exactly the mechanism that takes place. We shoot down the curve first because we fall down that precipice. Oxygen doesn't get delivered to the blood. Then the curve shifts because of the metabolic acidosis, secondary to lactic acidosis, and a fall again in the delivery of oxygen to the tissues, resulting in further acidosis. Any of those three conditions can give you this scenario. How do you treat these patients? Well, it's going to be different for each one. And this is something I now want to talk to you a little bit about, because you're going to face this at one time or another. If you're aware of this, you won't make this mistake. It's very important. Obviously, if the patient has primarily an oxygen deficit due to a pulmonary embolus or to a myocardial infarction, the thing you want to do is to try to oxygenate this patient as much as you possibly can. What do? You give oxygen, either by nasal cannula or through a respirator. What about the patient who has COPD? By the way, you'll immediately be able to distinguish between these conditions, because the patient who has a pulmonary embolus or has an MI is going to have a metabolic acidosis. The patient who has COPD is going to have a primary respiratory acidosis. Now, superimposed on this, as time goes on, there's going to be a metabolic acidosis secondary to this phenomenon that we spoke about before. But hold that in abeyance. Let's talk about the patient with COPD. That's the one I want to focus your attention on. Now, here's what happens. This patient builds up a huge amount of CO2. We end up with CO2 narcosis. Patient's nerves stop firing, gets paresthesias, motor weakness, it could even have a hemiparesis secondary to CO2 narcosis. He's obtunded, blunted. You've heard of the Pickwickian syndrome. The Pickwickian is from Charles Dickens. Pickwick was we usually see this in fat people who retain a huge amount of CO2. And this is a CO2 narcosis. They're blunted. They tend not to be very responsive. But there's another component of CO2 narcosis that's extremely dangerous, and that is that the respiratory centers stop firing in the same way that all the other nerves stop firing as a result of the high PCO2 in cerebrospinal fluid, in CSF. Now, since that's happening with this CO2 narcosis, the patient is going to stop breathing, and that's the worst thing that you can have happen, because you want to get rid of the CO2 in this patient, because remember, the primary cause of this stuff was the retention of CO2 and the disproportionate loss of oxygen saturation of the tissues. Now, what are you going to do? Well, the first thing that people say is, give the patient oxygen, just the way you would have given to the patient who has the MI or the PE, pulmonary embolus, because the more oxygen you get in, maybe you can counteract this effect of the CO2 in the alveolus. Now, you've just shaken your head. I'm happy to see that. What you realize is, I think, what you're really saying is that the patient doesn't stop breathing completely because there are chemoreceptors in the body that sense the fact that you have shoved yourself down on this curve so much. You've pushed yourself not only out of the saturation range, you put yourself into a lower PO2 range. Remember, the PO2 is going down disproportionately to the increase in PCO2. So the chemoreceptors are telling the lungs, don't pay attention to that CO2. Listen to me, you've got to keep breathing. So the lungs, the medullary, the respiratory centers in the medulla continue to fire under the effect of the chemoreceptors, despite the CO2 narcosis. Now you come along and you give this patient oxygen. What do you think is going to happen? The chemoreceptors are going to say, hey, I've got enough oxygen now. So now I'm going to stop sending my signal to the medulla. So the medulla says, oh, okay, I'll stop sending signals to the lung. So you stop breathing altogether and the patient dies. That is a very severe problem. That is why you must make this diagnosis between a metabolic and a respiratory acidosis. If it is a respiratory acidosis, there's a COPD there. If the PO2 has fallen and the patient is in severe distress with severe tissue acidosis as a result of this condition, your treatment to this patient, and by the way, the patient is going to be stuporous or probably even in frank coma. Your immediate first response is not to increase the O2, but decrease the CO2. How do you do that? Just get the patient on a respirator and set those settings nice and high. So the patient breathes, or you breathe for the patient, you breathe off that CO2 for the patient on the respirator. That will immediately shift all this back the other way. The first thing that will happen is that the PO2 will go up because the PCO2 will go down. And we can go back on that curve. Let me just show you that curve. We're back over here, and here it is. I shift myself back this way. Then I get back to the constant range. I can put myself back on the oxygen hemoglobin dissociation curve. I'll get less acidosis. I can go up the curve now until I get finally to full saturation, where the PO2 will reach 90 to 100 millimeters of mercury in circulating blood. Now that's what I really wanted to show you about arterial blood gases. I think what I'm going to do, I have a pharm exam. What I'm going to do, I'm going to stop here today. Next week, we're going to see patients. What I thought I would do, though, is just for 45 minutes prior to our going on rounds, what I will do is talk about liver function tests. You've all gone through it already. I want to summarize it for you and encapsulate it so that you will understand it. I want to show you how the liver function tests are related to other things, such as BUN and creatinine, hepatorenal syndrome, you may have heard of that. Electrolytes. Patients who have cirrhosis get ascites, that is water in the belly. You deplete serum volume, and there are very major effects on electrolytes. And I want to talk to you about that and how those values correlate and what you should look at and look for when you look at abnormal liver function tests and at the same time you have abnormal electrolyte patterns. Remember, and this is a principle I did not state at the beginning, it's Osler's principle. If the patient is 60 years or younger, then everything that you observe should be attributed to a single cause. Patients over 60, they're entitled to more than one cause. Nonetheless, you should try to put it all on one thing if you can. If you can't and they're over 60, then there may be more than one thing going on. But if they're under 60, get that one single cause and correct it. So next week, I'm just going to do liver function, and then I think you'll have a very nice, rounded view of how to interpret laboratory values. Now today, I wanted to spend time on this because these are vital measurements. If you cannot interpret these, you're not going to know what to do. There's one more thing I would like to say about this. Is this, by the way, clear? This is seminar style. I'm lecturing, but it really should be more seminar style because I really want to drum this into you so you know what you're looking at when you look at the charts and the values come back. Are there any questions about what we said so far? About the respiratory quotient, about how to make the diagnosis of metabolic versus respiratory acidosis or alkalosis? Okay, now, the last thing I want to talk to you about is the concept, and you will be using this on the wards, the concept of what we call the base excess. Base excess simply means how much bicarbonate do I have to give this patient? Or how much ammonium chloride do I have to give this patient? Okay? That's all it says. Now, what do I mean by base excess? Base excess is how much bicarbonate do I have? Suppose you have a patient who comes into the emergency room and he has a metabolic acidosis. You've ascertained that. The patient is very sick. You've got to correct that acidosis. that baby we saw, or the individual we saw, we had a baby at 6.9, another patient at pH of 6.8, that's incompatible with life. No enzyme can function at pH 6.8, not in the human body. So you've got to correct it. How are you going to correct that acidosis? You give the patient base. What kind of base do you give the patient? Well, it's the base that the body uses. That's bicarbonate. So we have to give the patient bicarbonate. Now, how much bicarbonate are you going to give that patient who has a blood pH of 6.8? Well, it turns out that we give you that number for you. That is, our machine, our blood gas analyzer, computes how much bicarbonate you should give that patient. How? Very simple. We know the patient should have a pH of 7.4. Now, we know what the Henderson-Hasselbalch, well, I'll write it in red. I want to use all my crayons today. So let's say the patient has a, get another sheet of paper here. pH, it's not writing very well, pH equals to 6.1 plus the log. Gee, Nick Goncharoff sure is getting chintzy. Let's see. Bicarbonate over PCO2 times some constant C, which is 0.03. Now, suppose my pH is 6.9. I want to bring that pH up to 7.4. So the equation I use is the following. I say I want a pH of 7.4. That's going to equal to 6.1 plus the logarithm of the bicarbonate. Now, the patient has a certain bicarbonate. Let's say it's 10. Now, how much do I have to increase my bicarbonate in order to bring that pH back up to 7.4? Well, for every mole of bicarbonate I add, I'm going to decrease 1 mole of hydrogen ion coming from carbonic acid. So, in the numerator, I have bicarbonate plus the amount that I have to add, and in the denominator, I have the CpCO2 minus the amount of acid that's going to get subtracted as a result of my adding that bicarbonate. Now, if I solve this equation for x, and you can do it, it comes out to be some kind of exponential number, which you can get right off the microcomputer chip that's in the machine. It actually will calculate that number x. X is the amount of bicarbonate you are to add to this patient. Now, you're not going to do it by just shoving it into the patient all at once. You're going to give it over a time span, an hour or two. Slow infusion on a line. You'll know how much bicarbonate there is in the bag. There are bags of sodium bicarbonate, and you'll give this to the patient slowly over a period of time, such that after a specific volume is given, the concentration of bicarbonate will reach this value, and the pH will be corrected to 7.4. That's the concept of base excess that I wanted to tell you about. And I mentioned to you before, if the patient comes in with a severe acidosis, you've got to correct it. And the correction is infusion of bicarbonate. The amount you give is given by our number that comes out of the laboratory as the base excess. Now, in this particular case, the base excess is negative. You have a deficit of base. Therefore, the base excess is negative. The patient has an alkalosis. He has a positive base excess. And then you're going to give, it's a corresponding number, except the signs change. You want to decrease the amount of bicarbonate, minus x, plus x in the denominator by giving an infusion of some sort of mild acid. And it'll tell you how much acid to add to correct that alkalosis to a normal pH of 7.4. That's all that number means. Okay, now having said that, we'll meet next week. Class will be divided into 7 groups of 10. I'll do it arbitrarily, but if you decide you want to shift groups, it's fine with me. And we'll talk about those patients the week after, and then see another set. And we'll take it from there. Huh? Yes, that would be very good. Please, yeah, dress nicely, because you will be seeing people on the wards. Not that you're not now, but I just meant. Yeah, thanks. Yeah.